Your doctor just scheduled you for a routine screening. You did not question it. You never do. But what I am about to tell you might change that forever. Because after over 20 years of practicing internal medicine and working closely with older adults, I can tell you this with absolute certainty. Some of the tests your doctor orders after age 65 are more likely to hurt you than to help you, and most doctors will not say that out loud. My name is Dr. Favor Adeyemi. I have spent my entire career helping patients over 60 navigate one of the most confusing parts of medicine, knowing when to act and knowing when to leave things alone. And today, I need to share something that goes against everything you have probably been told about preventive care. There are 4 routine medical checkups that I would not get after the age of 65. Not because I do not believe in medicine. I do. But because I have seen over and over again what happens when these tests find something in a 70 or 75-year-old body, and what happens is not always what you would expect. Before I walk you through each one, you need to understand one concept. It will change every medical conversation you have from this point forward. It is called the cascade effect. Here is how the cascade works. You go in for a routine test. The test finds something. The something looks like it might be a problem. So your doctor orders another test for a closer look. That test finds something slightly different. Now, there is a referral to a specialist. The specialist recommends a small procedure just to be sure. The procedure causes a complication. The complication requires treatment. And 6 months later, a person who walked into a clinic feeling completely fine is now managing 3 new diagnoses, taking 2 new medications, and is less functional than when the whole thing started. I have watched this exact sequence happen more times than I can count. Not because doctors are careless, but because medicine was designed to find things. And once something is found, the system is built to respond to it. The problem is that not every finding in an older body needs a response. Here is a second thing you need to understand. Most medical guidelines were developed using research on younger adults. They were then extended upward to apply to older patients without specific evidence for that older age group. The risk and benefit calculation that makes a test sensible at 50 can look completely different at 70. And that recalculation almost never happens in the room with you. Let me tell you about a patient I will call Theodora. Theodora was 73 years old, a retired teacher, active, independent, mentally sharp. She went to her annual checkup feeling completely well. Her doctor, following standard guidelines, ordered a full suite of routine screens. One of those screens, a test I'm going to name in a few minutes, came back with an abnormal result. What followed over the next 9 months was a cascade that nobody planned and nobody predicted. 3 more tests, 2 specialist referrals, 1 minor procedure that caused a minor bleed. The bleed required monitoring. The monitoring required medication. One of those medications caused dizziness. And Theodora, who had been completely independent, fell in her bathroom and fractured her hip. She recovered, but she was never quite the same level of independent again. The original finding from that first test, it was ultimately determined to be clinically insignificant. It was never going to hurt her, but the process of investigating it did. We will come back to Theodora because the question she asked me during her rehabilitation is one I believe every older adult in this country deserves to ask their doctor before agreeing to any screening. Checkup number 1, routine full body CT scans. Whole body CT scanning has been marketed heavily to health-conscious adults as the ultimate preventive health tool. You get a full scan from neck to pelvis. The machine checks everything, and you walk away knowing exactly what is happening inside your body. It sounds like the smartest thing you could possibly do for your health. Here is the problem. When you scan an entire body at 65 or older, you will almost always find something. Not because something is wrong, but because human bodies accumulate incidental changes with age. Small nodules in the lungs that have been there for decades without causing any problem. Tiny cysts on the liver or kidneys that are completely benign. Minor abnormalities in the spine that are normal structural aging. The medical term for these findings is incidentalomas. They are findings discovered incidentally that were never causing symptoms and were never going to. But here is what happens when the scan report comes back with those findings. Your doctor is legally and professionally obligated to investigate them, so the cascade begins. A lung nodule means follow-up CT scans every 6 months for 2 years. That is a significant radiation dose accumulating in a body that is already less efficient at repairing DNA damage from radiation exposure. Sometimes the follow-up scans look slightly different, and that triggers a biopsy. Biopsies of lung tissue in older adults carry risks of bleeding and lung collapse. A study published in JAMA Internal Medicine found that whole-body CT screening led to further diagnostic testing in 37% of participants, and that most of those findings were ultimately clinically unimportant. Meanwhile, the downstream testing caused real complications in real people. The radiation from a single whole-body CT scan is equivalent to approximately 3 years of natural background radiation. At 65, your cells repair radiation-induced DNA damage more slowly than they did at 40. Repeated scanning compounds this. The question to ask before any CT scan, do I have symptoms that this scan is specifically intended to investigate? If the answer is no, think very carefully before you agree. Checkup number 2, routine bone density scanning. After 80, DEXA scanning measures bone density and is used to screen for osteoporosis. For women in their late 50s and 60s, this is genuinely useful. Finding low bone density at that age creates an opportunity to intervene with medication and lifestyle changes that can meaningfully reduce fracture risk over the following decade. But after 80, the calculus changes in a significant way. Here is what happens when a routine DEXA scan returns an osteoporosis finding in an 80 or 85-year-old patient. The standard clinical response is to prescribe bisphosphonate medications such as alendronate or zoledronic acid. These medications are effective at increasing bone density readings on future scans. However, research published in the British Medical Journal and the New England Journal of Medicine has raised serious concerns about the use of these medications in very elderly patients. The first concern is a rare but serious condition called atypical femur fracture. With long-term bisphosphonate use, the bone structure can paradoxically become more brittle in specific ways, leading to fractures in the thigh bone that occur with minimal force and are extremely difficult to repair in elderly patients. The second concern is osteonecrosis of the jaw, a condition where the jawbone begins to die, which is particularly associated with these medications in older adults who have dental procedures. Here is the broader point. After 80, the goal of preventing hip fracture is best achieved not by treating a scan number with medication, but by directly addressing fall risk. Fall prevention programs, strength training for balance, home safety modifications, medication reviews to identify drugs that cause dizziness, these interventions have strong evidence for reducing actual fractures. A DEXA scan that leads to medication without a fall prevention conversation is addressing the measurement rather than the real problem. If a DEXA scan is suggested after age 80, the key question is, will the result of this scan change the treatment plan beyond what a fall prevention assessment would already recommend? If you have made it this far, you are clearly invested. You want to see what happens next. But most viewers enjoy the content and scroll away without subscribing. If this one really means something to you, tap subscribe. It takes a second. If not, you will probably forget this channel exists and miss a lot of great educational content ahead. Checkup number 3, carotid artery ultrasound without symptoms. The carotid arteries are the 2 large blood vessels on either side of your neck that carry blood to the brain. They can develop fatty plaque deposits over time, which narrow the artery and can potentially cause a stroke if a piece of plaque breaks off. Carotid ultrasound scanning is ordered routinely in many clinics for older adults as a stroke prevention measure. On the surface, this sounds entirely sensible. Find the problem, fix it before a stroke happens. That logic is appealing. The evidence does not fully support it. Here is the critical issue. The procedure used to treat significant carotid artery narrowing is called carotid endarterectomy. It is a surgical operation that opens the artery and removes the plaque. This surgery itself carries a risk of causing a stroke during or immediately after the procedure, because disturbing plaque in an artery near the brain is an inherently delicate and risky intervention. In patients who have already had symptoms, a mini stroke or TIA, carotid surgery has clear evidence of benefit. But in patients who have no symptoms at all, multiple large studies, including the ACST and AKS trials, have found that for asymptomatic patients over 70, the surgical risk of stroke equals, or in some cases exceeds, the stroke risk of doing nothing and managing the patient with medication alone. In other words, the test finds something, the something gets operated on, and the operation causes exactly the event it was supposed to prevent. The American Heart Association guidelines are clear. Routine carotid ultrasound screening in adults without symptoms is not recommended as a standard practice, yet it continues to be ordered regularly. If your doctor recommends carotid ultrasound and you have no symptoms of stroke or TIA, ask directly, if this scan finds narrowing, what is the stroke risk of the surgery compared to the stroke risk of simply optimizing my blood pressure and cholesterol medications instead? Ask for both numbers. You are entitled to both numbers. Checkup number 4, aggressive cardiac catheterization after a positive stress test. No symptoms. I saved this one for last because it is the one with the most serious potential consequences, and this is the checkup that I believe has the highest potential to harm rather than help in asymptomatic patients over 65. Here's how this scenario typically unfolds. A patient over 65 goes for a routine cardiac stress test. They have no chest pain, no shortness of breath during activity, no fainting, no symptoms of any kind. But the test is ordered routinely as a preventive measure. The stress test comes back with an abnormal reading. The cardiologist recommends cardiac catheterization, a procedure where a thin tube is inserted through an artery in the wrist or groin, fed up into the coronary arteries, and a dye is injected to image the blood vessels of the heart directly. Catheterization is an invasive procedure, and it carries real risks for older patients. Bleeding at the insertion site, arterial injury, kidney damage from the contrast dye, particularly serious in older patients with reduced kidney function, and a small but real risk of stroke during the procedure itself due to tiny air bubbles or plaque fragments that can be disturbed by the catheter. Here is the devastating finding from the Courage trial and the Ischemia trial, two landmark studies published in the New England Journal of Medicine. In patients with stable coronary artery disease and no significant symptoms, aggressive intervention through catheterization and subsequent stenting or bypass surgery did not reduce the rate of heart attack or death compared to optimal medical therapy alone. Medication managed these patients just as well with far less risk. This means that for an older adult with no cardiac symptoms, a positive stress test leading to catheterization and stenting may deliver all the procedural risks and deliver none of the protective benefit that the same medications would have provided anyway. The stress test has a high false positive rate in older adults, particularly in women. A positive result in a symptom-free patient sets off a chain of events that the research says may not be necessary and may cause harm. Before agreeing to cardiac catheterization, ask your cardiologist directly, do I have symptoms? And if not, what does the evidence show about outcomes for people like me who are managed with medication compared to those who go forward with the procedure? The answer should be a conversation, not a referral slip. I promised I would come back to Theodora. After her recovery, during one of our conversations, she asked me a question I think about every single day. She said, "Doctor, if I had known to ask one question before that first test, what question should it have been?" I told her the answer is always the same. The question is, if this test finds something, what will we do about it? And is that something worth doing at my age and in my current health? That is it. That single question, asked before any screening is agreed to, forces the conversation that the system is not designed to have with you automatically. It makes the doctor think about the cascade before it starts. It puts you at the center of the decision. Theodora told me she wished someone had taught her that question 30 years earlier. I am teaching it to you now. Let me bring this all together with clarity and confidence. 4 medical checkups worth very careful thought before you agree after age 65. Routine full-body CT scans that find incidentalomas almost guaranteed to trigger cascades of investigation for findings that were never going to harm you, while delivering accumulated radiation to a body that repairs that damage more slowly with every passing year. Routine bone density scanning after 80 that leads to bisphosphonate medications with serious risks in very elderly patients when fall prevention programs have stronger evidence for reducing actual fractures. Carotid artery ultrasound without symptoms, where the surgery triggered by findings can carry a stroke risk that equals or exceeds the stroke risk of doing nothing and optimizing medications instead. And the most important one, aggressive cardiac catheterization after a positive stress test in a patient with no cardiac symptoms, where landmark trials show that medical therapy alone achieves the same outcomes without the procedural risks that can cause exactly the events you are trying to prevent. None of this means avoid your doctor. I will say that clearly, and I will say it once. Preventive medicine saves lives. Blood pressure management, diabetes control, vaccination, vision and hearing checks, annual medication reviews, these are valuable and important. What I am asking you to do is go to those appointments prepared. Bring this question with you. Write it on a piece of paper if you need to. If this test finds something, what will we do about it? And is that worth doing for someone my age? Ask it before every screening, every single time. Your doctor will either have a good answer, in which case proceed with confidence, or they will not have a clear answer, and that itself tells you something important. Which of these 4 checkups surprised you the most? Tell me in the comments. I read everyone. And if you have ever experienced a medical cascade yourself, where one test led somewhere unexpected, share that in the comments too. Your experience could help someone sitting in a waiting room right now make a better decision. Share this video with someone you love who is over 65 and goes to every scheduled screening without asking a single question. The most important thing you can do for their health today might be giving them the one question that changes everything. Subscribe for more honest medical conversations that put you in control of your own healthcare decisions. I am Dr. Favor Adewumi. You deserve the full picture, always. Disclaimer: everything shared in this video is general medical information based on published research and clinical guidelines. It is not personal medical advice for your individual situation. Every person's health history is different, and some individuals may have specific medical reasons why these screenings are appropriate for them despite their age. Before making any changes to your scheduled medical care, please have a thorough conversation with your own physician. This video is a starting point for that conversation, not a replacement for it.